Thanks.
Recording has started.
Welcome everyone to this week's Endocrine Grand Rounds. It's my pleasure to introduce Dr. Paul Hiers. Dr. Hiers is a pediatric endocrinologist who joined us in August of this year. He received his training at the University of Florida School of Medicine and went on to residency and then fellowship also in Florida in Gainesville. He has extensive interest and experience in diabetes care. He is a huge advocate for our patients with diabetes, particularly in camp outreach. And he also has some extensive experience working in a variety of multidisciplinary clinics in Florida, including those related to bone, as well as the care that's provided to patients with Duchenne's muscular dystrophy, which is a perfect segue now into today's talk. And so today he will be talking about the endocrine aspects of Duchenne muscular dystrophy care. Please welcome Dr. Hiers.
Thank you, Dr. Wintergers, for the warm welcome. I'm sorry I can't meet you guys in person, so I will do my best with the virtual presentation to hopefully we all learn a little bit about the endocrine aspects of Duchenne muscular dystrophy care. Like Dr. Wintergers said, so I'm straight out of fellowship. I did all my training in Florida at the University of Florida, so go Gators. That's I always have to say that. And as part of that experience, I had the opportunity to work with a lot of providers that provide excellent care for our patients with Duchenne muscular dystrophy. So I want to share some of the knowledge I've gained during my fellowship to you all. So our overview and goals. Want to review the pathophysiology of Duchenne muscular dystrophy, discuss the steroid therapeutic indications in DMD, compare the progression of growth and puberty in DMD with or without steroid treatment, explore the steroid-related side effects leading to adrenal insufficiency, impaired growth, delayed puberty, and bone fragility, and then provide screening and treatment guidelines that are available to us now. I have no financial conflicts or other conflicts of interest to disclose. If anyone has some suggestions, I am open to them. And then today's event code is here below. I'm sure Kelly will place it in the chat section as well for everybody. So without further ado, so why this topic? So I wanted to talk about this for a couple reasons. Through my personal experiences during my fellowship training, this was not something I went into fellowship expecting to learn about, and it kind of happened in a sense by accident, or was kind of meant to be. One of the first patients I saw during my fellowship was a Duchenne muscular dystrophy patient in my fellows clinic. And it wasn't really a child. He was 18 years old, followed by our neurology clinic for years and years and years. And come to find out during our conversation, he's been on steroids for greater than 15 years. No one's ever talked to him about adrenal insufficiency. What is Solu-Cortef? What are you supposed to do if you're having surgery? Are you supposed to stop the steroids abruptly? Never had that conversation. He was also 18, but his testy sizes were 3 cc's, so he had never went through puberty on his own. He had multiple fractures during his life, including a femur fracture, and he was in a wheelchair when I saw him. And so it just started getting me interested in, well, why hasn't this, young person ever seen endocrinology for a variety of issues that we could have helped with earlier on in his care? And it come to find out it wasn't just him. There was a lack of endocrine involvement in a lot of kids with Duchenne muscular dystrophy. The other reason I wanted to pick this topic was because I felt there was a big overlap between pediatric and adults, and I think this is like a lot of other pediatric conditions like cystic fibrosis, where in the past the mortality from these conditions really didn't allow them to kind of reach the adult world. And so now that with new therapies, there's actually genetic therapies becoming available to our kids with Duchenne muscular dystrophy, they are going to start to come to the adult clinics. And so I thought this would be a good topic to kind of bridge our two areas of expertise. And then not necessarily improve our knowledge gaps. There is a lot of data that is not well-studied data, meaning not randomized controlled trials, because like many other pediatric rare diseases, there's just not large numbers to do these type of trials. And so trying to get the onus on us as pediatric endocrinologists and adult endocrinologists to study these diseases further. A lot of the things I'm going to talk about is not going to be surprising or enlightening to an endocrinologist. And so we are very familiar with the aspects of steroid management and its multitude of side effects that we see, but kind of synthesizing them all into one thing makes it to kind of show like what the course of treatment in these kids are, I think is important. So an overview. So Duchenne muscular dystrophy, it's an X-linked recessive neuromuscular disorder due to a mutation in the dystrophin gene. Dystrophin is a protein, and it's very important for functional muscle fibers. You can think of it as like the molecular shock absorber for the individual muscle fibers. And so without this, or with a malformed dystrophin gene, you can cause damage to the muscle fiber. The prevalence is 1 in 5,000. Most cases are diagnosed on average between the age of 4 and 6 years of age. And then the clinical course is typically progressive weakness with eventual loss of ambulation, and there can also be cardiac dysfunction as well as respiratory deterioration. Kind of the classic clinical scenario that you would see in a patient with Duchenne's that presents is they have the pseudohypertrophy of the calf muscles, and then an exam finding is the Gower sign, where they will stand from a seated position and they'll walk up their legs to be able to stand. How does dystrophin work? So your muscles are made up of bundles of fibers, and these are grouped in interdependent proteins along the membrane. And so the dystrophin is kind of the linkage between the muscle fiber membrane and some of the extracellular portions. Within Duchenne muscular dystrophy, typically the dystrophin gene is either absent or totally non-functional. There's another type of muscular dystrophy called Becker's, and it's kind of on the spectrum of Duchenne muscular dystrophy, but a much milder form. It's typically due to either an inadequate amount of dystrophin. DMD is an X-linked recessive disorder, so that means males are typically affected, but females can be carriers. The pathogenesis of DMD is believed, so it's based on this defective dystrophin gene. That will lead to decreased quality or quantity of the dystrophin protein, which will eventually lead to damage at the individual muscle fibers. Eventually, within the body, damage leads to death of these muscle groups. So the body has two ways of trying to combat this. So it tries to activate satellite cells to repair the muscle fiber, but because of the damage, there's actually background inflammation going on at the same time as well. This inflammation releases different cytokines, which eventually leads to fibrosis and scarring. And so this fibrosis is what kind of leads us down this progressive muscle weakness, because the fibrosis interferes with adequate muscle repair at the cellular level. And then it leads to further damage of individual muscle fibers. So there's just this kind of cascade effect that continues until there's loss of ambulation. So steroids are the only treatment to show benefit thus far in Duchenne muscular dystrophy. They're working on many different genetic avenues to help this syndrome, but there are some starting to come out. One is available, it's called Exondys 51. It's a type of antisense therapy, but it's only in particular types of DMD that have a particular mutation. It's not available to all. So you can kind of think of it like the CF therapies that we have that are tailored to certain mutations. But besides that, it's steroids which have shown the benefit. So in studies using glucocorticoids, it's shown to slow disease progression. On average, it prolongs ambulation for about 2 years. It has been shown to reduce the frequency of scoliosis, and then it can also improve cardiorespiratory function. Many patients with DMD now live into their late 20s, early 30s now, whereas traditionally, this was a disease that you wouldn't make it out of your teenage years in. As we know with our steroids, they do provide some benefit, but there are some harsh side effects to talk about, especially on the bone. So if you start steroids before the age of 5, it actually doubles your risk for fractures in DMD. The steroid options are typically prednisone, which we're all familiar with, and then there's another steroid that I think is used pretty exclusively in DMD. I haven't seen any other condition that's used. It's something called Deflazacort. I'm not sure how familiar you guys are with this, but Deflazacort's another type of glucocorticoid. It's about 3 to 4 times as potent as hydrocortisone. The recommended doses in DMD for the therapeutic dose is 0.9 mg per kg per day of Deflazacort, and then prednisone, the dose is 0.75 mg per kg per day. Traditionally, this medicine was available in Europe for many years, and our patients at the University of Florida, a lot of them used Deflazacort, but they had to actually import it from Europe. It is now available in the U.S. under the trade name Inflaza. Of course, what happens anytime drugs come on the market in the U.S. is our patients were paying $10 in Europe for Deflazacort, and now it's hundreds of dollars here in the United States. The reason people have used Deflazacort instead of prednisone is due to some of the side effects. Some of the initial studies using Deflazacort showed a trend that it actually improved ambulation time, and that there was less side effects in terms of less weight gain compared to prednisone. These were small studies with small numbers. They weren't randomized controlled trials. They were more observational than anything. And so this is an area that needs a lot of further study. The natural history of Duchenne muscular dystrophy typically would include loss of ambulation by 10 years, and that's without steroids. With prednisone, ambulation would continue to about 11 years and 2 months. The graph on the right shows the red line is the natural course of disease. The black line is the patients that used prednisone. There's another study that showed that Deflazacort actually had a bigger benefit with ambulation. And so that's the green line in this Kaplan-Meier curve. The other color curve, so the black line in this Kaplan-Meier curve is prednisone, and then the yellow and red lines are different variations of prednisone. So within the DMD community, some people will use prednisone either on a daily basis, or sometimes they'll do high doses just on the weekends, or they'll do alternating doses. And it showed within this observational study that the Deflazacort dose was superior to all those. There was many problems with this study because it was mainly observational and not a randomized control trial. Also, some of this data is derived from Europe, and so different mechanisms of care and delivery of the healthcare system can influence kind of different ambulation outcomes. And so they were using the Deflazacort data from Europe, but some of the data was actually from the US for prednisone. So are we comparing apples to apples, or is there a difference in the regions of the world that use this? So clearly steroids are, somewhat beneficial, but what about the side effects? And so that's what a lot of our talk is going to be about today. So Not surprising to endocrinologists, but if you're on steroids for quite a prolonged period of time, adrenal insufficiency is quite a significant side effect. I don't need to go in the pathophysiology of adrenal crisis to a group of endocrinologists, but the point here is this is not something that neurologists typically talk about a lot, unfortunately. So within the guidelines and within the community of muscular dystrophy itself, this kind of came to a head based on a patient called PJ Nicholhoff. So he was a young man that had Duchenne muscular dystrophy for 20 years. He was visiting Florida on vacation and unfortunately had an injury where he broke his leg and broke his arm. He was flown closer to his home institution, but didn't quite make it there, and he had to have emergency surgery on the way. He ended up not making it because of a multitude of reasons. During the post-mortem, it was concluded that, during his surgery, no one ever gave him steroids. And during his post-op course, he was never on stress dose steroids or even restarted on the steroids he'd been on for the previous 15 years. So that kind of was like a wake-up call to the DMD community that there needs to be some education involved in these type of events because they are greatly at risk for it. Anecdotally, in my experience, I see a lot of children with DMD that have been on steroids for years and years and years and have never heard of Solu-Cortef or has never been prescribed or educated about it as well, which to me can be quite scary. Typically, the therapeutic dose of prednisone and deflazacort is well above stress, and so they don't necessarily need a stress dose. They just need to continue that dose if they become ill. And then there needs to be education around, well, are there times when they cannot take their regular dose of deflazacort and prednisone? So if they get a GI illness, if they're going in for surgery and are made NPO. I've even seen kids where if the providers feel like the steroids are not beneficial anymore because they're non-ambulatory, and their advice is to stop the steroids abruptly. So there's a lot of education involved in this. The incidence of adrenal insufficiency is not well studied within DMD, but there is evidence of morbidity and mortality among case reports and unexplained deaths within the DMD community. This diagram is from the Lancet guidelines on Duchenne muscular dystrophy, and then the green side is talking about timeline and dosing. And so not really the endocrinologist's job, it's the neurologist's job to decide when to start therapy with deflazacort or prednisone, and then kind of how to adjust it based on response and side effects. The orange side is where we should be involved and hopefully educate our neurologist colleagues, educating them on adrenal insufficiency for the family, providing them Solu-Cortef stress dosing, surgery, and anesthesia recommendations, and then they actually named the steroid tapering protocol after PJ Nicholhoff for a wean plan to wean these kids off steroids. So other side effects, not surprising to us with chronic steroid use, is obesity and steroid-induced diabetes. There actually is a lack of data for this community with that, meaning that so that we know about in one cohort, 50% of 13-year-old males with DMD were obese, but the true incidence of steroid-induced diabetes is actually unknown. Looking at other conditions that require large doses of glucocorticoid, such as rheumatoid arthritis, it's about 18%. One adult study, and these are adults, so not kids, showed impaired glucose tolerance in about 53% of the DMD group and 46% of the Becker's muscular dystrophy group. And about 13% of them met ADA criteria for type 2 diabetes. Interestingly, though, only 32% of those adult patients were actually on steroids, whereas 0% of the Becker's kids were on steroids. From my personal experience and anecdotally, I have not seen very many, I can think of maybe one child that was on, that had diabetes mellitus from their steroids, which I find very interesting because I would expect to see more of them. So I don't know if there's some underlying condition related to the Duchenne muscular dystrophy that's either protective or is just kind of an interesting thing without a lot of data backing it up. Growth. So impaired linear growth is thought to be partially due to the underlying disease that's definitely exacerbated by glucocorticoid therapy. So even without steroids, short stature was commonly seen in kids with Duchenne muscular dystrophy. Steroids obviously make a big difference on that, especially when they're on it, sometimes at age 5 or 6, and they continue on that throughout most of their growing years. In one center, short stature was seen in about 72% of patients on steroids and only 10% in the steroid naive group. The mechanism is due to growth plate toxicity from the steroids, primarily through inhibition of chondrocytes and osteoblasts. There's also the growth hormone IGF-1 axis that is disrupted from chronic steroid use. It's important, even though it's quite common to see short stature in DMD, and it can be caused by the steroids, is not to have your blinders on. And so these kids can also have underlying thyroid disorders, can have true growth hormone deficiency, celiac disease. So you need to evaluate for other causes of growth failure in these kids as well, and not just chalk it up to it's the steroids doing it. Other things to consider is when they're not ambulatory anymore and wheelchair bound, using other measures to monitor the growth, such as arm span or seated heights, would be more beneficial than using a standing height. And then growth hormone is actually not very well studied in DMD. And then there's some studies that showed that it may exacerbate scoliosis, which can lead to interference with cardiopulmonary performance in DMD. And earlier studies suggested that tall stature might be detrimental to muscle function in DMD. This is a similar algorithm for kind of to follow. So, growth assessment using height should be monitored every 6 months until completion of puberty. If there's any signs of impaired growth, they should refer to an endocrinologist that does an assessment to look at, different causes of growth and to consider growth hormone stimulation testing if that's indicated. Other aspects that can be impacted is puberty. So delayed puberty due to hypogonadism is observed in this population and definitely exacerbated by glucocorticoid treatment. And it also inhibits the hypothalamic pituitary gonadal axis. The timing of steroids actually matter, and so children that are started very young on steroids are more likely to have aspects of delayed puberty, whereas patients that are started maybe a little bit further along in their course may be able to spontaneously go through puberty on their own. Delayed puberty can affect quality of life, and so now that our patients are living much longer, they want to go through puberty. They want to have sexual function. They want to have relationships. And so having these questions and addressing them for our patients is very important. Also, it's very important for bone health. And so we all know from hypogonadism that if you don't go through puberty, your bones are not optimized and as strong as they could be. The recommendations are for testosterone replacement by 14 years of age, which is typically what we decide is the upper limits of when males can start puberty. You can consider earlier at 12, especially if you have a high index of suspicion that they've been on steroids for quite a long time. You can actually start a little bit sooner at your discretion. There are further studies that need to be underway to look at outcomes in terms of skeletal health, muscle function, quality of life. We know testosterone is important for muscle as well, and so what effect is this having on muscle that might not be particularly normal because of the dystrophin protein? And so there is a concern potentially could we be causing harm by doing testosterone, but right now there's no proof of that. It's all theoretical. One study for puberty and DMD showed that in males 11.5 years of age, 97% of them were still pre-pubertal, and they were quite short. Similarly, like another center, 43 out of 44 glucocorticoid treated boys were pre-pubertal by 11 years of age, and so this is these steroids are delaying our puberty quite a bit. It appears, though, unlike growth, pubertal development does not appear affected in the absence of glucocorticoids. So prior to the steroid era of treatment in DMD, they actually had spontaneous puberty on their own. So this seems to be primarily glucocorticoid-mediated effect. Similar to our growth guidelines, physical assessment of puberty should start, around the age of when puberty should be started. If testicular volume is not greater than 4 cc's, then they should refer to us and we should perform an evaluation. For pubertal induction, there's no specific guidelines for DMD. It would just be the same as any male we see that has hypogonadism. So kind of like a standard routine is sometimes initiating at 14 years of age, 50 milligrams per month of testosterone cypionate. You can consider in boys greater than 12 as well. And then you increase this monthly to simulate normal puberty in males. And then either by increasing the dose or increasing the frequency. And then once they're on the adult dose, you can consider switching to gel or patch. It's unclear right now, just because of there's this lack of data, if this needs to be just through adolescence to get them through this, and then maybe if they come off steroids at some future time point, will they spontaneously continue through puberty on their own, or is this something they're going to need lifelong replacement on? The benefits of testosterone therapy, so besides virilization, sexual function, which is desired by a lot of the males, it can help with growth acceleration, so getting the pubertal growth spurt. Also might be important for muscle and fat mass. Not in DMD, but in other conditions with hypogonadism, testosterone therapy improves bone density by about 39% after 1 year. And so this just kind of is a point that proves that, testosterone in kids that are already at risk for bone fragility is an important consideration. Also, quality of life, mood, and self-image is important as these boys are developing. They want relationships, they want to go to college, they want to do all the stuff that testosterone helps them with. Finally, in the kind of the largest aspect I'm going to talk about is bone health and Duchenne muscular dystrophy. So 60% of DMD patients will have a low trauma extremity fracture, and that's without glucocorticoid therapy. So they're already at super high risk of fractures, even without steroids. Using steroids actually will increase their risk by double. 50% of those fractures will be, with glucocorticoids, will have symptomatic vertebral fractures, which is quite a large number. But there's a large amount of vertebral fractures that will be asymptomatic, and they will go undetected in the absence of active monitoring. So that means we have to be looking for them. We can't rely on patients telling us that they have back pain to look for a vertebral fracture. Vertebral fractures can occur as early as 6 months following glucocorticoid initiation, so that's quite early. On average, it takes 2 to 3 years after start of glucocorticoids before they'll have an asymptomatic vertebral fracture. So, like I said, early detection is key. This is just something visual to see. So on your left is a boy with Duchenne muscular dystrophy receiving steroids for many years that has a fracture. And so most of the fractures in DMD will occur kind of at the end of the long bones. And then on your right is a healthy boy. So you can see just the kind of the brightness of the bone. It looks not as healthy. It's much smaller than a child without Duchenne muscular dystrophy. So there's from just them their poor muscle function that leads to less stress on the bones, and as well as the steroids, it can definitely you can appreciate a change in their overall their bone quality. Why is this important? So bone fragility, if untreated vertebral fractures, will lead to chronic back pain, which can be quite debilitating. They can actually, when not addressed, lead to spinal deformity, and that spinal deformity can lead to cardiopulmonary compromise. There's something within the DMD literature called the vertebral fracture cascade, and so having a vertebral fracture is actually predictive of having future fractures, either of long bones or continuing to have more vertebral fractures. This fracturing in DMD is what leads to non-ambulation and quite a bit of morbidity, and so that's why it's important to address these. Leg fractures and long bone fractures can lead to significant loss of ambulation, which will be premature and typically permanent. Once a child with DMD has a long bone fracture, they typically will be in a wheelchair due to the recovery, and chances are they will not make it out of that wheelchair. That is what kind of takes them off their feet. That can lead to quite a decreased quality of life, being wheelchair bound. It can actually be quite dangerous too. With long bone fractures, you can have death due to fat embolism. So the keys of this are osteoporosis prevention and treatment, as well as like using agents such as bisphosphonates have actually been linked to increased survival in these patients. The key is prevention of the first fracture. And so how do we go about doing this? The first steps we all know about, so optimizing their calcium if their diet isn't sufficient in calcium, so finding what their recommended daily intake should be and following the guidelines. I typically will screen them for their calcium in their diet, and if they're lactose intolerant or just don't eat anything with milk, cheese, yogurt, fortified fruits, and fruit juices, I will place them on calcium supplementation. Care needs to be considered, as we don't want to increase their risk for kidney stones either. And so monitoring for that if they're on calcium supplementation is recommended. Optimizing the vitamin D. Who doesn't need some vitamin D? It feels like nobody really gets enough vitamin D either in their diet, and so supplementation is optimized. Physical therapy is extremely important, and continued exercising is really, really important. And unfortunately, sometimes getting PT that's effective and consistent is definitely needed and not something that's always a priority. Imaging in DMD. So they're actually, in the recent guidelines for this, there's a shift from using bone mineral density using a DEXA to use that as the diagnosis of osteoporosis in the setting of steroid use. And so the reason for that is steroid vertebral fractures can occur in children with BMD, bone mineral density Z-scores greater than -2. And so having a low BMD is not very predictive of having a vertebral fracture. So these need to be actively monitored. The ways to screen these with lateral plain films of the thoracolumbar area. If they're on steroids, they need to be monitored at baseline and then yearly thereafter. If they're not on steroids, they need a baseline film and then every 2 to 3 years at a minimum. During visits, if they complain of any lower back pain or you're concerned of a vertebral fracture, you can always obtain a plain film sooner. I'm going to show you other imaging modality, but there are DEXA films of the spine that you can use as well. It depends on your center and if you have a DEXA machine that can do the spine imaging. There actually is specialized radiographic interpretation. It's called the Genant scoring, and it kind of gives you a grade of how severe the compression fracture is. Right now, there is not primary prevention for these fractures. And so there are studies underway of using bisphosphonates in people that are at risk because they're using glucocorticoids continuously, and they're anticipating that their bone fragility is going to get much worse. And so we're awaiting results of a few studies to see if primary prevention is kind of the way to go waiting until they have a fracture, because it kind of goes against the thought process of we're trying to prevent a fracture. Like, why are we waiting until they fracture before we give them a treatment such as bisphosphonates? This slide shows the importance of screening for vertebral fractures. And so in this study, this is showing children that were monitored for compression fractures on an annual to biennial basis versus no routine screening. So as you can see, the green bars are those with screening. The mean age of detection of their first fracture was much younger than those that weren't receiving routine screening. The mean time since they started glucocorticoids was much younger. And then the number of vertebral fractures per patient was much fewer if you're actively screening. And so that's what's important about screening for these compression fractures and why we're moving away from using a DEXA scan with bone mineral density. So these have to be actively looked for. Besides a plain film, there are vertebral fracture assessments by DEXA. And so this is just kind of showing you kind of a very pretty picture of what that can look like compared to the more traditional plain film looking for vertebral fractures. And so the DEXA looks very nice. And so hopefully different institutions have different capabilities. But if we have a DEXA machine that does spinal films, it will make it a lot easier to detect and see these type of fractures. The other nice thing is usually to get a spine film, you need to order a T spine and an L spine to kind of get the full breadth of what you're looking for the vertebral fractures. Whereas with the DEXA, it'll be on all one image in one cassette, so you don't have to order different things. This Genant scoring I mentioned. So I'm not a radiologist, so I'm going to do my best, but it's just a way that's validated in children to kind of score the vertebral fractures. The indication for using bisphosphonates is actually when you have a low trauma vertebral or long bone fracture, or if you have a mild or moderate vertebral fracture. And so what this grading is, so it either grades like a grade 0 is normal, a grade 1 is mild, a grade 2 is moderate, a grade 3 is severe. And what it's looking at is the vertebral height loss. And so with a mild grade 1 score, you have about 20 to 25% vertebral height loss. With grade 2, it's 26 to 40%. And with grade 3, it's greater than 40%. And so it's just, and also another way to kind of monitor treatment as well. Studies have shown that with bisphosphonate therapy, children with DMD can actually regain some of this vertebral height loss. This is a phenomenon seen in children. Adults typically do not, if they have vertebral fractures, they're not able to regain some of this vertebral height loss. And so that's something that's important because that could show us improvement in their compression fractures and actually prevent some future morbidity. And then kind of just to show you guys what you should be looking for in some of these plain films is just kind of different aspects of it. So you can have loss of the end plate parallelism. So you're kind of looking for nice, kind of clean borders of the spine. And so in that first picture on your far left, you start to see a little bit of hyperlucency, and it's not as smooth and straight as compared to this other segment here. Sometimes you get anterior cortical buckling, so kind of in the middle, it kind of pushes in from the side. And then sometimes you can see end plate interruption as well. So there's this kind of nick here in the typical smooth surface of the vertebral spine. So what's the treatment for bone fragility in these children? So within the pediatric literature, IV bisphosphonates are superior to the PO forms. there is a potential reasons for this is they have less efficacy potentially due to low bioavailability, so you don't absorb as much through the gut as when you get it through IV. Another reason the recommendations are for IV is that it's specifically superior compared to PO in terms of vertebral height remodeling. And so this is not in the DMD population that this has been seen, but this is from the OI literature where in the IV bisphosphonates, you can actually have vertebral height remodeling, which would theoretically lead to improved morbidity and mortality. Whereas with the PO bisphosphonates, there was no evidence that it remodeled the vertebral heights at all. A consideration is therapy is initiated before completion of adult height, and to improve that vertebral height gain. And then, as stated before, there's been no evidence that if you're an adult that has some vertebral height loss due to compression fractures, there's no evidence that you regain it on these therapies. We're all pretty familiar with the bisphosphonate side effects. The most common thing we typically see is the acute phase reaction flu-like illness. We see this very commonly. It's usually very common with the first dose, and it can be dose dependent based on its severity. And then with each subsequent dose, it can be either milder or not happen at all. Hypocalcemia is a potential complication as well. Where I trained, we actually would pre-medicate a week before and for a week after, giving them calcium supplementation, just to make sure that they were tanked up in a sense, to make sure that they wouldn't have any falling calcium levels after. Allergic reaction is mentioned as a potential side effect, though I've never seen or heard of anybody that's had allergic reaction to bisphosphonates. More common in the adult literature, so you guys are probably more familiar. But different types of atypical fractures have been reported in adults. There is a theoretical risk in growing bone, and so right now the guidelines are that we should be continuing bisphosphonates if we start them in children until they are done growing. The thought is if you start therapy and then stop therapy, the new bone that is being laid down and growing children might be weaker than the bone that has the bisphosphonates that's part of the matrix. Also in the adult literature, but not reported ever in pediatric literature, is osteonecrosis of the jaw. So again, this is kind of the diagram for bone fragility through the guideline. That includes, monitoring for back pain, asking about fractures, which we all do, assessing some baseline metabolic bone disease labs, and then annually screening calcium, vitamin D intake, vitamin D levels, getting DEXA films and spine films, and then deciding whether or not they meet criteria for treatment or not. And so I traditionally used zolindronate or zoledronic acid at University of Florida, just because of its ease of use, and it was we were able to use it a lot, twice a year, and instead of 4 times a year compared to pamidronate. The guidelines don't have a preference for which type of bisphosphonate to use. There's actually no data in DMD stating that one is particularly superior within DMD. Within the OI population, it shows that between pamidronate and zolindronate, they're at least equally efficacious. And so I like zolindronate because of its ease of use and the frequency that it has to be used. Within this population, there's a treatment phase of the bisphosphonate, and then there's a maintenance phase. And so in the literature, you will use the bone mineral density to guide your treatment onto what dose of bisphosphonates you will use. So takeaways from my presentation, and hopefully we'll have a good discussion after this. Hopefully I've convinced you that in our DMD patients, they definitely need endocrine involvement for their optimal care, in the areas of adrenal insufficiency, growth, puberty monitoring and induction, and particularly bone fragility. And there's large areas of study needed within pediatric DMD. And then as survival improves and different therapies come on board, these patients are going to come to our adult providers and colleagues. And so being able to study that from a pediatric side and an adult side is going to be crucial in knowing what kind of therapies are working and which ones aren't. There's a lot of different aspects to think about within Duchenne muscular dystrophy, and this is what I want to kind of bring to the group as we're finishing up. How do we go about doing these kind of next steps? So kind of future aspects of care is some of these are basic. Some are assessing the incidence of adrenal insufficiency and just appropriate education for these patients. Some are studying, like, is there a different steroid regimen that's more optimal? There's currently studies undergoing looking at, using bisphosphonates or other therapies prophylactically as primary prevention. I will have to defer, and I hope any of my adult colleagues have any input on this within kind of glucocorticoid-induced osteoporosis, but the use of agents that we never see in pediatrics, but using denosumab like Prolia or anti-sclerostin antibodies or PTH in these patients, like that could have some bearing in pediatric DMD. There's just nobody's looking at it. Nobody's doing studies in this quite yet. And then lots of randomized controlled trials need to be undertaken involving Deflazacort versus prednisone, growth hormone versus IGF-1, RCTs using testosterone. Is there an optimal pubertal induction evaluation and protocol that should be used? And so that's where there's just a lot of data that's lacking within this population. But also that's something exciting for me, because I know it's an area that needs to be addressed. Hopefully you'll have access to my slides through Kelly, and so these are just some resources to the guidelines for DMD, and then the parent project that has a lot of resources for families, and then lots of my references. And I thank you for your time and attention, and I'm happy to answer any questions and comments that you guys have.
Hi, this is Satya Krishnasamy, one of the adult faculty. Nice overview. Thank you. I know these are strange times. We haven't met you personally, but thank you for doing the talk. So I had a couple of questions. I do you had alluded to cystic fibrosis also. So I do take care of the young adults in our interdisciplinary CF clinic with the bone issues. In fact, I know Dr. Winters is on the call, and we did have an abstract last year. And my question was, which you had, I was planning to ask, and you already put up the question, so you already answered, or at least put out the issues that we wanted to discuss. So one was, you had mentioned the sclerostin antibody, and also about the anabolics and the MAB, rank ligand monoclonal antibody in children. So in adults, at least with the anabolics, one of the issues is it's the limit of the time that we have to use it, only up to 2 years. And usually we try to save them for severe, which is almost like the patients we have here, multiple fractures or severe osteoporosis, where you usually use it for 2 years and then you follow it up with the anti-resorptive agents. So I know in children there's not any studies about these agents, but certainly that's a very interesting area. My other question was the growth hormone, because I recently was looking at some endocrine abstracts, and one of the things was in anorexia, use of growth hormone, IGF-1, or I think actually it's growth hormone treatment for bone density improvement. And of course, they didn't use your usual traditional DEXA parameters, which again is an issue. We go with the gold standard dual density. Is there other ways to do it, such as trabecular or QCT or MRI or other ways, that bone markers, if you will? So So my question was about the growth hormone, especially I thought in this group of children and adolescents where there's so much issues with the growth, and that is that something, have there been studies with that or?
Not well conducted studies, not randomized controls, more observational than anything. Some of the earlier studies with it, and it could be just because of kind of a different time in the course of treatment with DMD, where they use growth hormone, either they saw no effect, and the part of the theoretical reason was because maybe they're just on, continued glucocorticoids during that whole time, and it's just so toxic to the bone. And
That's
so
right.
even
That's
though
right.
you're giving growth hormone, it's not doing anything at the bone level. The concern in the initial studies was a small portion of the people on growth hormone, I think, actually did a little bit worse from like bone, from muscle. Like they would do like walk tests and stamina type tests, and whether it was truly the growth hormone that was doing it, or is just a small study where some of the worst kids were in that kind of aspect of the group.
I see.
It's hard to say. The other part of it was kind of in the past where they become kind of wheelchair bound. There's this bias that, the smaller kids are a little bit easier to kind of take care of because they become totally dependent at some point. And so, making them a little bit bigger would kind of affect the care at home in that aspect. So unfortunately, there's not good, well done studies using growth hormone. I've myself used growth hormone in a very few number of kids that we did a kind of like a trial because they were kind of begging to do it because they were just kind of psychologically devastated by the height, and he was really affected by it. It helped that he was from Brazil, and so he spent like half the year from Brazil, and so that's where he would get his growth hormone from. So they weren't paying an arm and a leg, and him, he got no effect whatsoever, and so that's and then of one, so not very helpful. But it's just there's just not a lot of data supporting growth hormone within Duchenne muscular dystrophy. And then to your point about those other agents, those are exciting. Thinking of kind of at different points during our treatment, could we be using anti-sclerostin or denosumab at earlier points in the early on in the use of glucocorticoids if we know it's going to be a short-term thing. But the problem is this is a long-term, glucocorticoids are going to be there quite a long time. And so is it adjunctive? Could it be used to kind of buy us a little bit of more time to prevent a fracture? Potentially, it's all theoretical at this point. And so it's interesting times to be able to think of kind of what kind of avenues are open.
That's right. Yeah. Thank you. I'll let the others ask more questions.
Thank you.
Thank you.
Well, if no one's going to ask, I'll butt in. Steve Winters here. Nice to meet you, Paul. So in adults anyway, people taking large doses of glucocorticoids, long-term primary prevention is advocated for bisphosphonate. So there are many adult diseases where patients take steroids lifelong. And as soon as you start the steroids, the studies have all shown that primary prevention with bisphosphonates improves the bone density and fracture risk over time. So unless there's some contraindication for using it in children, it would seem that that same type of philosophy would apply. And whether you want to do a randomized study to show that or not, I guess, you need a lot of patience, and you'd have to put together a multi-center trial. So the thing to do is to talk with others in the field and see what they're doing. But at least from adult medicine, primary prevention with bisphosphonates was certainly quite acceptable.
And that makes sense to me. A lot of the other kind of advocates within the bone world of DMD, such as Leanne Ward, I think the kind of guidelines are probably going to move towards that with using it as primary prevention. But I don't know of anybody that's doing it quite yet, even though I think a lot of people want to. I think there's just a difference with starting at such a young age, where they're typically being initiated with glucocorticoids at age 5 or 6. The concerns about how long are we going to leave them on bisphosphonates for? Is it going to be as long as they're growing, which is, potentially a decade or more when they start at 5? So there's just a lot of questions. But I agree with you that using something to prevent the fracture makes total sense. And so I just don't know of anybody that's kind of doing that yet, where they're starting 5-year-old kids with DMD on bisphosphonates, though I think we could be getting to that point at some point in the future.
So as regards to the testosterone deficiency, if they really are profoundly testosterone deficient, once again, I'm not sure that there's really any downside to instituting testosterone replacement. That'll help with their bones and help with their muscle strength to some extent, maybe. So,
Yeah, definitely.
Again, I would think that would be a standard of care too.
Yeah, it is. So usually they say at least by age 14, but when I see kids, usually if by 12 they're not having any signs whatsoever and they've been on large doses of glucocorticoids, I will usually try to induce them, and then if they can spontaneously go through puberty on their own, then I'm happy. But typically they need like pubertal induction because of the effects of glucocorticoids. They are not going to go through spontaneous puberty on their own.
Well, there's lots of reasons. I don't think it's only the glucocorticoids why they're gonadotropin deficient. They're sick, and the connection between nutrition and growth and the somatometer, and it is a problem. But why are they short? Are they very, very short in a wheelchair? Is it because of all the spinal fractures primarily, or what? What's that? Your story was that your patient's parents were most concerned about the short stature. So why are they short?
So before the steroid era, they were short, and it might have been because they had because of their fractures. They had more fractures at younger ages. Spinal fractures, spinal deformity can affect their height. More recently, it's because of the steroid era. That's one of the bigger effects on short stature.
Okay, thanks a lot. I myself have been interested in myotonic dystrophy. And in fact, I've been working on a little review of endocrine disorders and myotonic dystrophy here in my retirement. It's only partly done. I did that because the first paper I ever wrote was in 1975. Was about myotonic dystrophy, and I've always been interested ever since. Did you see many of those cases too?
Not many. There was a center in Orlando, which was south of us in Gainesville, that saw more of the myotonic dystrophies. So all of them went there.
I see. Thank you.
Thank you for your question.
Okay, if there are not any other questions, thank you. So we'll see you again in 2 weeks, because next week being Thanksgiving, we won't have anything. So we'll be back in 2 weeks. Thanks.
Thank you for having me. Hopefully I'll meet you all in person at some point after 2020 and COVID is over with.
Yeah. Thanks.
Great work, Paul. Have a good night.
Thank you.